Okay, hi, my name is Kinsey Pennington, and this is my lower limb case study. So before we go into the actual case, there's some anatomy that we should cover first. So there are 4 myofascial compartments in the lower leg. The first one being the anterior compartment. You can see over here that it is red in both of these pictures. Next is the lateral compartment. You can see it over here in the blue. After that, a deep posterior compartment seen over here in green in both pictures. And finally, the superficial posterior compartment seen in purple over here. So for the anterior compartment, the muscles are the tibialis anterior, extensor hallucis, extensor digitorum longus, and the peroneus terratus. And the innervation is the deep fibular nerve. You can see it in this picture over here, highlighted in red, going down the front of the leg into the foot. In the lateral compartment, the muscles are the fibularis longus and the fibularis brevis that you can see on the side of the leg. And the innervation for this compartment is a superficial fibular nerve. You can see it up here at the top lateral part of the leg, highlighted in blue. It's kind of just peeking out of the muscles. In the deep posterior compartment, the muscles are the tibialis posterior, the flexor hallucis longus, the flexor digitorum longus, and the popliteus. And the innervation is the tibial nerve that runs down the back of the leg, and it branches off of the sciatic nerve at the knee. And the last one, the superficial posterior compartment, the muscles are the gastrocnemius, which here it's cut out so you can see the soleus muscle underneath. But here's the head right here, and here's the calcaneal tendon that it connects to. And then there's the plantaris that is behind the head of the gastrocs. And the innervation is also the tibial nerve. Well, okay, there it goes. There's the dorsal pedis artery, and it's highlighted in green in this picture. You can see it runs down between the first and second toe. This artery is a major blood supply for the forefoot, and from this we can find the dorsal pedis pulse. It can be felt in between the base of the first 2 metatarsal bones. If there's a weak or absent pulse here, that can suggest that there is poor blood circulation in the foot. Okay, so the case. A 24-year-old female arrived to the emergency room 18 hours after she is released from the hospital for a tibial fracture. Previous to her emergency room visit, 18 hours before, she was diagnosed with a displaced mid-shaft fracture of her left tibia in a skiing accident. She underwent a closed reduction of the fracture and was fitted for a cast and given pain medication. But now 18 hours later, even though she's been taking this pain medication, her pain is worse and the cast is becoming tighter. She had a physical examination. She told them that she felt pain when she would flex or point her foot. She had a weak left dorsal pedis pulse, which tells us that there's poor circulation in her foot. There was a visible bulging of her muscles in the anterior leg compartment, and the skin over that anterior leg compartment was tense and shiny, and she had little to no feeling in her first 2 toes. So the lab findings, her compartment pressure was 33, which is abnormally high because the normal is below 10. And I may say this wrong, the serum creatinine phosphokinase, that was 2.1, which just like the compartment pressure test is abnormally high because the normal is between 0.5 and 0.9. So the first possible diagnosis is acute compartment syndrome. That is just a type of compartment syndrome. So compartment syndrome develops when swelling or bleeding occurs in a certain compartment in the body, which in this case would be the anterior compartment of the lower leg. And because the fascia that separates the compartments doesn't stretch, this can increase pressure on the capillaries, nerves, and the muscles in the compartment. This disrupts blood flow to the muscles and nerves, leading to damage of nerve and muscle cells. So in specifically acute compartment syndrome, permanent disability and tissue death may result if the pressure isn't released. So, and acute compartment syndrome pretty much only occurs after a severe injury, such as a tibial fracture. And causes are a fracture like our patient has, badly bruised muscle, crush injuries, constricting bandages, and steroid use. So some symptoms of acute compartment syndrome are severe pain, tingling or burning sensations in the skin. The muscles may feel tight or full, numbness or paralysis, and difficulty moving the foot. For acute compartment syndrome, there's not really any treatment that doesn't involve surgery because it is a surgical emergency. So they perform a procedure called a fasciotomy, which is when the skin is cut open to release that pressure. In some cases, when they're stitching the skin back together, it is so swollen that the skin is too far apart. So sometimes they do need to use a skin graft for that. A second possible diagnosis is deep vein thrombosis. This is when a blood clot forms inside of the body. Symptoms of this can be swelling in the foot, ankle, or leg, severe cramping pain. The skin over the blood clot is warmer than the surrounding skin, and the skin over the blood clot is also pale or a reddish or bluish color. This was really interesting, but only about half of the people with this condition suffer from the symptoms of it. Causes can be injuries that result in damaged blood vessel wall, surgery, reduced mobility or inactivity, and certain medications can also cause this. Some risk factors too are having a bone fracture like our patient has, being overweight, having a family history of deep vein thrombosis, having a catheter in the vein, being on birth control or undergoing hormone therapy, and smoking. So treatments for this involve medication. There are compression stockings that can lower swelling and actually prevent blood clots from forming. Filters can be put in the vena cava to stop blood clots from entering the lungs, and also surgery is an option too. Okay, so the final possible diagnosis is necrotizing fasciitis. This is a rare bacterial infection that spreads quickly in the body and can even cause death. It most commonly enters the body through a break in the skin. This can come in the form of cuts and scrapes, burns, insect bites, puncture wounds as small as an IV, and surgical wounds. Also, it can occur without a break to the skin through blunt trauma, just like our patient has. Some symptoms of this is red, warm, or swollen area of the skin, and that can spread quickly. Severe pain, fever, ulcers or blisters, change in the color of the skin, dizziness, and fatigue. So some risk factors for this are diabetes, kidney disease, scarring of the liver, and cancer. There wasn't a lot of treatment that I could find on this, but some other than surgery and medication, but some good prevention that you can do is taking time to properly clean and treat open wounds. And if you do have a cut in the skin, avoid spending time in hot tubs, swimming pools, or other natural bodies of water. So after looking at these three, I believe that this patient has acute compartment syndrome. She does have some of the symptoms of the other two, but I believe her symptoms almost 100% match acute compartment syndrome because it does usually only occur from a severe injury. A lot of patients who do have acute compartment syndrome were actually in car crashes. And yeah, her symptoms seem to match this the best. She had severe pain. Her muscles felt tight because her cast was getting tighter. She could not feel her first two toes, and she was having a lot of pain and difficulty in moving her foot. And that's all. Thank you.